So we think of this as precision personalized medicine, right? You're going to be treated exactly based on what you have in your arteries, as opposed to, we know if we treat a population with so much that so many of them are going to improve. So it's precision diagnosis and therapy, but it's on a very personal basis.
Yes, yes, fabulous. Well, would you mind showing us a few of those examples of the different types of plaques so that the listeners can understand, or the viewers can understand, how beautifully clear it is that we can see what's going on?
Happy to. Give me a second to bounce over here and let's see, I got to change my field of view here a little bit.
And while you're looking, pulling that up, is there any future aspirations to look in any other arterial beds with the artificial intelligence?
We would like to expand into the carotids, and we have some research that we are currently doing, looking at the carotids. It's the same technology. You look at the type and the amount of type of plaque that's there, as well as whether there's stenoses there. And if you think about it, if you were able to both look at the heart and the carotid simultaneously, you have 2 of the 3 leading causes of death, and for cerebrovascular disease and heart disease, and potentially get it in the same examination. So our early research has shown that you can actually do a heart CT, then quickly scan the carotids, and we can get the same out. Now, we have to get some more data and apply to the FDA, so that probably won't be a product for us for a while, but that is definitely on the roadmap for us to look at in the carotids also, because stroke and the death and disability from stroke is still quite high, of course.
Yes, yes. Wonderful, wonderful news.
So here I can show let me just find a good case to have an idea. So this is the software that it uses 6 different machine learned algorithms to analyze the CT scan, and it segments out all the coronary arteries, which you can see here. And if I jump over to the left on this gentleman, so we're looking at the left main coronary artery going into the left anterior descending. So these are the biggest arteries coming out of the heart. And as you come over here, I'll show you what it looks like in cross section. So here we've sort of bread sliced it into cross section. So the yellow stuff here is non-calcified plaque. The blue stuff is calcified plaque. And then these little red plaques are that low density plaque that I talked about earlier. So as we scroll up and down, you can see that there are a couple of deposits of that red plaque. So this red plaque, which is also called low density plaque, clearly has the highest risk to the patient. On the CT scan, it's actually the darkest plaque, and it's dark because it contains liquid cholesterol and triglycerides. And what happens if inside the circle here, the purple line, this is the inside of the blood vessel that we're showing longitudinally here. So that's where the blood is flowing. The plaque is built up in the wall here. If this ruptures into the vessel, this is what causes an acute heart attack. So what happens is, if the blood is exposed to the liquid cholesterol in here, immediately a blood clot forms within seconds or a minute. And this is what causes an acute coronary syndrome. You're walking down the street, you're playing basketball, you're even watching TV. And when that red plaque is exposed to the blood, clot forms, you can cut off blood flow to a large part of your heart muscle, and that can cause an acute event. So that's why we see great success in actually with therapy, getting rid of that type of plaque. So if you put the patient on good therapy, in a year or 2, that plaque can completely disappear. We have many examples where we can successfully get rid of that. We also have lots of examples where we take the yellow plaque here, which is sort of turns out to be gray when I take the color off, and we convert it into the calcified plaque, which you see here. And the calcium, it's a scar, you don't really want to have it, but of the 3 types of plaque, that's the one you want more of. So, we convert the plaque that can cause acute syndromes into this more benign plaque that, it causes very little problems. And we can even track it over time. So we do have ways. We have several reporting tools. I'm happy to show you that. If you look at this case, we have a PDF format that can go back to the patient. And the patient, this is what they can, I'll show you the provider report first. For the providers, we sort of a summary of the data. We don't believe that the primary care providers, or frankly, even the cardiologists, will actually read or interpret those images. That's our job as imaging physicians. But we provide a report that has a summary. Here we see the total plaque volume in this patient was 566, which is pretty high, puts them into the upper quartile probably for their age. We do see that we get some of that low density, that most dangerous type of plaque. And, in this case, there were, fortunately for this patient, even though they had that plaque, there were no stenoses. So this patient probably didn't need a stress test. And if they had a stress test, it would be negative. But what they really need is some therapy. They need therapy to transform that plaque. And we even have a way I can show you on our software to show that plaque is transforming in the right way. So let me get plaque progression. Sorry, here we go. Plaque regression follow-up exam. So we do have part of our software. If you have a patient who's had a prior study, we have a compare feature that you can see here. So on the left-hand side, you can see this patient had a scan in 2017. They're on therapy for about 17, 18 months, and they came back. And you can see here that this was successful. The total plaque volume initially was 445, and that went down to 311. So that's down 30% reduction. So that's very unusual. A 30%, we don't see a 30% reduction very much. So I don't know particularly what this individual patient was on, but they were on the right things, I can tell you that. If you look at the low density volume of plaque, remember that's the most dangerous of all types of plaque. So that went from 67 down to 32. So they even had a greater reduction in that. So they still have some room to continue where they're going, but clearly this patient is headed in the right direction. The overall plaque volume is down. The non-calcified plaque volume is down. The low density plaque volume is down. And the only thing that's increased is the calcified plaque. It's gone from 2 up to 13. And that's where the other plaque has gone to. They've transformed the other type of plaque into this benign calcified plaque. So unquestionably, this person is on the right therapy. We can even look at it on an individual basis of like one plaque compared to another plaque, which is probably a little bit too granular information for a lot of folks. But I think, just knowing that their therapy is successful can be great. Whereas we can look at another patient and show that the patient has failed therapy, unfortunately. So here we have another case. And when we compared 2 studies, you can see here that been just very different. It's gone from 64 up to 195. So that's more than a doubling of the patient's plaque. The low density plaque went from 0 up to 4, et cetera. So this was clearly a failure of therapy, in which case this patient would benefit from either intensification of whatever therapy it's on, or perhaps, like we said earlier, there are up to more than 10 medications that are available now that can be used. And we know that diet also can do this. There's a study, the DISCO trial in Poland last year that was published, randomized clinical trial where both sides were already on optimal medical therapy, but then they put one side on a monitored diet. And over the period of the study, they showed the people on the diet side actually were lowering their low density plaque and non-calcified plaque, whereas in the optimal medical therapy side, they were still progressing. So just diet alone can be an additive factor. And there's other examples of other interventions that can be very helpful.
Fabulous. That's so helpful to see this.
This might be an interesting case for you. So we often get patients who have a 0 calcium score. And as you probably know, a calcium score is also based on a CT scan. It's not as sophisticated a scan as CT angiography, which is what we do here. And it looks for only one type of plaque, which is a calcified plaque. So this patient had a calcified plaque score that was 0, but they actually subsequently developed chest pain. So then they went back and actually had a CTA. So even though this particular patient had that negative plaque form, they wound up still having a fair amount of atherosclerosis. Sorry, I was showing you the wrong vessel. So even though they had a 0 plaque, which has a 10-year risk that's very favorable, this is the gentleman's left anterior coronary artery. You can see there's a huge plaque here and a significant narrowing. So look at the diameter of the vessel here. Look how narrow it comes here. Not only is it narrowed significantly, but he's got quite a bit of that red plaque, the low density plaque that we saw earlier. Just because someone has a 0 calcium score doesn't mean that they don't have plaque. It doesn't mean that they don't have high risk plaque. And it also doesn't mean that they don't have a stenosis. So we've seen lots of examples of that. So calcium scoring may be good to establish that there is disease, but it can also, in some situations, give you a false sense of security that there's nothing going on when there can still be quite a bit going on in those situations.
I'm so glad you showed this example because any patients of mine that are listening or watching, or some viewers that have had one, there are a lot of myths to dispel with that coronary artery calcium score test. You're exactly right. It's a great test, especially before we had Cleerly, because I tell patients it'll tell us yes or no, is there plaque? What it doesn't tell us is just what you said, is it dangerous? And of course, now we can say we would like to see on Cleerly, is it red? Is it that lipid rich dangerous type of plaque that's also there that the coronary calcium score type of test won't see.
I mean, it does have the advantage of being more affordable than
Yes.
a CT, so there's still some utility for it. The other thing it can't do is actually then evaluate the success of therapy. So if you have it, the patient's on therapy, and you get another calcium score. Well, unfortunately, if your calcium score goes up, you don't know whether your calcium score goes up because all of the plaque is still progressing, or you've transformed your dangerous, risky plaque into the calcified plaque. So it can't be used to disease track because it can be confounding. You may walk away with the wrong implication for it. So that's why generally it's a one-time, just say, hey, you have disease or not. But even when it says you don't have disease, there's still a chance that you do have some disease there, unfortunately.
Mm-hmm. Great points. Yes, absolutely. So now, if you have a coronary artery calcium score that's 0, well, I would recommend a coronary angiogram with Cleerly. And then if you have a coronary artery calcium score that's positive, you still need a coronary artery angiogram with Cleerly, because we need to define what's beyond the calcified plaque, as you've just said. So we know how to track it in the future.
100%. And some of the challenges we have is as we are growing, not every center in the U.S. is attached to us. So we do have different ways of coming. We do have centers that we work with directly, and we have we're sort of wired into, and we have financial relationships with. But there are lots of other people who may be able to get a coronary angiogram where they live, but they're not at a center that's connected. So in those situations, through a physician like yourself, they can get a scan at a third party, still upload the scan to us, and we can analyze it. So it doesn't have to be a Cleerly related center. There's lots of places in the United States now that do coronary angiography.
I'm so glad you brought that up as well. Yes, we've helped coordinate a couple of those that weren't connected with Cleerly, but can still be done. So I even had a patient who had a previous coronary artery angiogram, I think a year or two ago. And so she went back and got the images, and we were able to get them to Cleerly and still get it analyzed. So it's great.
Yeah, most imaging centers, you're legally obligated to retain the records of the study for 7 years. So even if you had it several years ago, because nowadays we have people who we scan and they're like, hey, I had a scan 3 years ago. I know I have disease now. I want to see where I was 3 years ago. And so we will then analyze both of those and use that software to say, hey, you've stabilized. Whatever you and your doctor are doing is the right thing. Keep doing that, right? Or sometimes, unfortunately, we show, hey, you've doubled your plaque volume since 3 years ago. Either you're a failure of the therapy that you're on, so you and your physician should have a discussion about changing your therapy, and then come back in another couple of years, and we'll see if that was successful for you.
Yes. Great. Fantastic. So I want to reiterate to all of our colleagues listening to please don't just click to the next video and say, oh, that's great. I hope somebody's doing that. And really think about offering this to your patients, because primary care, family practice, nurse practitioner clinics, PA clinics, this needs to be offered on a wide scale access across the United States for sure, and world. Do you have anyone sending in scans from outside the United States?
We actually have a number of very large research studies across the world. We have one called Confirm 2, in which we're involved in, I think, 22 studies worldwide. On commercial basis, that we're only active in the United States currently, but we are looking for CE mark approval in Europe and Japan. So we do certainly have plans to operate internationally on a commercial basis, but currently it's all research.
Fantastic. And for those who are listening who are not our colleagues, definitely write down cleerlyhealth.com. Is that the website?
Cleerlyhealth.com.
Mm-hmm. And Cleerly is spelled Cleerly, clearlyhealth.com, to learn more and to look for under the location utility on the website to find a location near you, or seek out this test by asking your physician, your nurse practitioner, your PA to please order it for you. And then, as you've said, you all apparently have some resources if they can call there if they need help locating someone, or can call my office, of course, and we'll help them as well. What other key points would you make, both either for our colleagues or for the general public, or people with coronary artery disease, that perhaps we haven't touched on?
Well, I think that, we need to all understand that it's the largest killer in the United States, and most people don't know what their own personal risk is. And we've had a failure of identifying people with early disease. So I think that this provides a mechanism for knowing what your risk is. I think hardly any of us don't know somebody who just dropped dead of a heart attack. I myself, I had a 52-year-old brother-in-law who was an orthopedic surgeon, father of 4, was probably the most fit person I knew, did everything correct, rode his bike 300 days a year. And he got out of bed one morning and unfortunately suffered an acute coronary syndrome. And he never would have been the person that would have been worked up using traditional methods. He didn't have chest pain. He didn't really have risk factors of disease. So the system as it exists would not look at him. But had he had a Cleerly and a CT when the months or years prior to that episode, there's a very good chance that never would have happened, because he would have been identified and put on the right therapy. So, and as my colleague Terry said, it's scary to find out, but once you find out, there's lots of good things. We have the right therapy, lots of options for the right therapy, lots of options for individuals. You just need to find out and do it.
I couldn't agree more. Absolutely. Thank you so much. It must be very fulfilling for you to see this come about with all your years of work and sort of merging the worlds, as we started this conversation in the beginning, merging cardiology, interventional cardiology, radiology, the MRI, the CAT scan, like which technology are we going to use? You've lived through the history of all of that and really been an innovator. So I congratulate you.
Thank you. Well, we've been able to take it from being something that was intellectually curious and fun to do to, hey, we really will and can change the world using this technology. And that's what we want to do. We can actually save lives and not just write papers and not just make additional income. We can really make a difference. And that's what we're very passionate about at Cleerly.
Oh, that's fantastic. That's exactly right. So those patients that are listening, or people who've heard me get crazy excited about this test, now you can see why. That paragraph that you just said really sums it up. We can really change the world and save lives. And I look forward to the day when we can see that number of 700,000 deaths a year and even more people that are presenting to the hospital. We can see those numbers start to lower. And that's really possible now using Cleerly AI.
Yeah, I'm 100%. I'm convinced that if we use this technology judiciously and in the right people, that we will lower that number and think about how many lives then that'll affect. Because it's not just the 700,000, it's all their children and wives and husbands and mothers and fathers that you affect too. So we really do believe that we have a great opportunity here to make a great difference.
Yes, absolutely. Thank you so much for your time today and for your wisdom and sharing your expertise. I appreciate it. It's been a delight to get to know you and to share your information with all of our viewers.
Well, thank you. Same here. I thank you for your faith and your early adoption of our technology. It's always wonderful to work with people who believe in the same things that we do. And together, we're going to make a difference.
Yes, yes, we are.